Welcome to Channel 17, the Town of Colonie Government Channel.
Hello and welcome to Focus on Health. I'm your host, Peggy Mello. Today's guest is Dr. Scott Osur with Certified Allergy and Asthma Consultants. Welcome to the show.
Well, thanks, Peggy. Thank you for having me here.
Why don't you tell our viewers a little bit about your practice?
Oh, okay. Well, we have a allergy practice in which we have 7 physicians and a few different offices in the Capital District. And we focus on the care of all sorts of allergic conditions, from nasal allergies, which are certainly blooming this time of the year, not to make a pun, to hives, to bee stinger allergy, to medication allergy, and perhaps most importantly to asthma, which we see a lot of throughout the whole year.
Okay. And let's talk about, we're talking about asthma today. Let's talk about incidence and prevalence.
Sure.
What about how many adults and children are affected?
Right. Well, asthma is a condition that's become increasingly prevalent in the United States in the last 20, 30 years. And nowadays it's thought that perhaps 2 to 5% of adults have asthma, and upwards of 5 to 10% of children. So particularly in childhood, any classroom in an elementary school may have 1 or 2 asthmatics in it. And this was a much more uncommon condition when I was a child a few years back.
Okay. And what about how many fatalities per year? Do you have those numbers?
Yeah, I mean, asthma, one fortunate trend in the field of asthma is there's less asthma deaths now than there were a few years back, probably because we're better with our medication use and better with patient compliance. In the United States now, there's about 3,500 to 4,000 deaths from asthma. About 10 years ago, it was up to 5,000 to 6,000.
Oh, boy.
And the interesting thing is that we really think that a lot of these deaths can be prevented if patients get good early diagnosis and good care and are on appropriate medication.
And ER visits and hospitalizations, are they frequent?
Very frequent. One of the most common reasons actually a child can end up in the emergency room for a medical condition or be hospitalized is asthma, and adults frequently as well. There's a couple of million emergency room visits a year in the United States and over 500,000 hospitalizations, so it's a very common problem.
And the thing that's probably undefined is the lost time from work, right? Whether you're an adult with who has asthma or you have a sick child.
Sure. No, absolutely. You're quite right. We don't think typically of the adults, of the children with asthma, but they have to take time off of work. They're less effective in the workplace because of that. And then adults with asthma frequently miss days of work when they catch a cold, and they don't just get a head cold, they get a chest cold that lingers for a few weeks. They miss a few days of work and be less productive. So it's extremely important in terms of quality of life and lost work and school time.
Now, honestly, I never knew that asthma had anything to do with allergies. But can you kind of explain why they're related?
Well, yeah, asthma is considered an allergic condition. What makes it confusing is there are some asthmatics which have what we call intrinsic asthma, where they have no allergies. It's just sort of part of themselves, and they may be aggravated by respiratory infections or exertion or cold air. And then there are extrinsic asthmatics who have allergy, where fundamentally allergy chronically irritates their airways, causes mucus and inflammation, and predisposes those individuals to even more significant asthma problems. And in children, perhaps upwards of 2/3 of children who have asthma have allergies. In adults, the numbers are a little less pronounced than they are in kids, but very common to have allergies and asthma together.
Now, what about the world view? I mean, are there certain parts of the world that have more asthma than others?
Yeah, an interesting question, and the answer is yes. Asthma and allergy are conditions of developed countries, westernized countries, very uncommon in third world countries. And so you find the prevalence in Western Europe, United States, developed countries in the Far East like Australia and Japan very high. And if you look at poorly developed countries, perhaps in Central America or Africa, there's a lot less frequent asthma and allergic disease.
Interesting. So if I had asthma, would my children possibly also get it through hereditary means?
Yeah, there is a strong hereditary component to asthma. We know for asthma as an allergic disease, if you have two parents who have allergies or asthma, the chance that a child will have allergies or asthma is about 75%. So there is a strong genetic component if they're family members with the condition. But there still can be children that develop asthma even without their parents have allergies or asthma. But certainly if your parents have it, you're more likely to contract one of these allergic conditions.
And how does what you call the hygiene theory affect numbers?
Yeah, the hygiene theory goes a little bit to the cause of why there's more allergic disease and asthma in the United States and Western societies. No one really for certain knows the cause, but one of the more prevalent and more common theories that people believe in is the so-called hygiene theory. And essentially it says that as we've become better with hygiene in Western society, more frequent use of antibiotics, less exposure to certain bacteria in infancy, that has pushed the immune system that we all have away from fighting infections towards developing allergies. And there's actually cells in our body called T cells that move in a certain direction that produce more allergy if you have less of these infectious exposures.
So maybe this has something to do with underdeveloped countries, if they don't perhaps use antibacterial wipes as often.
Right. Well, there is something to that. If there's less antibiotic use, less sanitary conditions, there's actually less allergic and asthmatic disease. Not that any of us would want to go to a third world country and have all the infectious diseases that they have and all the dangers from that. But there is something different in Western society fundamentally that does move us towards allergic conditions and asthma.
And what about evidence-based medicine? Have they done many studies on asthma, and you kind of know where the protocols are going?
Well, in my particular field in allergic disease, asthma is probably the best studied in terms of doing basic research and clinical research looking at how you treat asthmatics. And the National Institute of Health, going back to the 1990s, has established algorithms and protocols to treat asthma depending on what the symptoms are that a patient has, depending on how much they need their rescue inhaler, depending on whether they've been in emergency rooms or hospitalization. So there is a definite program that tells doctors, not only specialists, but general practitioners, how to treat asthma based on this particular protocol.
Now, this might be a surprise question, but are there many diseases that the NIH has not developed protocols for?
Well, I can only speak well to my particular field, and asthma has been worked out pretty well. Allergic rhinitis or nasal allergies has been worked out fairly well, but other conditions, the protocols aren't as well established based on multiple scientific studies. Not to say that we don't have good treatments for it, but the background of information that leads to treatment decisions isn't as worked out. And for example, one area might be urticaria or hives, how to treat that. There aren't as much evidence-based protocols out there as there is, for example, asthma treatment.
So evidence-based is kind of like, if this, then this. If this is defined or this lab value is this amount, then something else.
Yeah, and to take it a step further, evidence-based means that there's a number of well-designed studies that have proven that treatment regimens really work, as opposed to maybe one or two studies or anecdotal information or even expert opinion. There's actually scientific studies that support what you're doing.
Good. Okay, let's talk about diagnosis. How is one diagnosed with asthma?
Well, the asthma diagnosis initially comes down to symptoms that the patient presents to a physician, whether it be a general practitioner or a specialist. So many of these that your listeners will be familiar with are wheezing, shortness of breath, chest tightness, chest heaviness, and cough. And if you have these symptoms recurrently, provoked by certain factors such as bad colds really settling in the chest, exercise producing shortness of breath or cough, cold air bringing on symptoms, or perhaps an allergy exposure, then you have some pretty good evidence that that individual may very well have asthma.
Okay. And are there different severity levels that the NIH defines?
Right. Yes. Asthma currently is put into several categories. There is a category of very mild intermittent asthma, where the asthma is very infrequent and all they need is a rescue inhaler to use very infrequently. And then there are persistent asthmatics who have more chronic and daily and weekly symptoms that vary anywhere from mild to moderate and severe. And again, there are algorithms based on NIH protocols that tell us how to treat each of these stages of asthma.
So at some point of severity, you're going to have to take your medication with you at all times.
Right.
Kind of like an EpiPen, right?
Right. As a matter of fact, most asthmatics should always have their rescue inhaler available, even the mildest, because you just never know when you're going to be in a situation where you may have an asthma exacerbation. You might, for example, have very mild asthma, only bothered by cat exposure, and then you go over to a friend's home and all of a sudden they've gotten a pet cat. You go in there and have wheezing and chest tightness and you need to have your inhaler. So basically you should always have your rescue inhaler available, just like as you mentioned, someone with peanut allergy must always have their EpiPen available.
Right. Now, are there other ailments out there that might be confused with asthma?
Yeah, I mean, asthma many times is a straightforward diagnosis, but there are some conditions that can mimic asthma or be confused with asthma. There are individuals who are chronic smokers who may have COPD, chronic obstructive pulmonary disease, which although a bit related to asthma is different, and they may have similar symptoms. There are people that have acid reflux and get chest discomfort and chest pain that they think might be asthma, but it's really from the reflux. Rarely there are people with cardiac conditions that can also be confused with asthma. And then sometimes you can have breathing difficulty when the vocal cords function improperly, and you can get wheezing and chest tightness and shortness of breath, but it really is from your throat rather than down in your lungs. So there are conditions that sort of masquerade as asthma or complicate asthma. But I would say an asthma diagnosis is not the most difficult. It's getting the right treatment that one really needs to work with.
But there's no actual radiographic exam or blood work that you would see that would say, aha,
There's
this
asthma.
is it.
Well, a chest x-ray can be suggestive of asthma, but it's not absolutely diagnostic, you're right. And there's no blood test that actually identifies asthma. There is a lung function test that's very useful called spirometry. And if you go to many primary care physicians' offices, or allergists or pulmonologists will oftentimes perform a lung function test, see what it looks like, then give someone an asthma medicine and look for improvement. And that can be a very good way of objectively diagnosing asthma. And that goes hand in hand with your review of the symptoms that the patient presents with.
Okay. Now, let's say I'm an asthma patient. What would be the difference of being followed with a primary care physician and being followed by an allergy specialist?
Well, in the United States, most patients with asthma end up getting their primary care for their asthma through their pediatrician, internist, or family physician. And part of the reason for that is there are just so many asthmatics in the United States. I mean, there's probably 10 to 15 million asthmatics, and they can't all see specialists. So it is very reasonable to start with the primary care physician and initiate treatment. Primary care physicians in the United States and in the Albany area are excellent in general, diagnosing and beginning treatment. I think it comes to a point where if the asthma isn't easily controlled with simple medicines, or they suspect there's some allergic component, then it makes sense to send to a specialist, do some allergy testing, do some lung function testing, maybe try some medicines that the primary care might not feel comfortable with using right away. But indeed, primary care physicians can do a very good job with most asthmatics.
I just figure I would rather, let's say if I had an allergy to a particular tree, instead of somebody telling me, well, you can just take an allergy medicine every day, I would really kind of want to know what tree is it.
Sure.
And you can test that, right?
That's correct. I mean, if someone comes to our office and they have persistent asthma, which requires daily medicine, we do allergy testing to see if we can identify any chronic or acute allergy triggers. And a lot of what I do as an allergist is preemptive sort of medicine, precautionary, where we try to find out what can aggravate their condition to try to avoid it, to do environmental control measures, potentially even consider allergy desensitization injections to make them less allergic. So I do agree it's very important to know what you're allergic to try to avoid it. But on the other hand, his initial step, primary care, certainly can find the right medicine, get someone on, and see how they do. And if they're not doing well, still having symptoms, then send them along for further workup.
And how frequent would you have to follow up with somebody? Does it depend on severity?
Well, it does, although that's an interesting question, because I think one of the problems with asthma care in the United States is we're good in starting treatment, but we're not necessarily good in following up with patients, because many times we'll just have them come back when their asthma gets worse. And really, one of the key things with the National Institute of Health NIH guidelines is that asthmatics should really be followed back routinely at least every 6 months.
Every 6 months.
And if you make a change in their asthma regimen, you might even want to get them back in the next month or two.
Okay.
So I think one of the things that would be very helpful for all of our listeners to know is once you get treatment, you don't want to just wait to your next attack to be seen. You want to follow up with your regular doctor or your specialist to make sure you're doing as well as you think. And I might add one other thing, which is interesting about asthma, is about half of asthmatics out there are really poor perceivers of their asthma. They have asthma that's going on, and they sort of adapt to it, and they don't realize that they're not as good as they can be. And so that's part of the reason to get these routine follow-up appointments, to do lung function testing, really go over symptoms, and make sure that they're doing as well as they should be doing.
But is the nature of the disease, does it generally change from week to week? Are you better some weeks than other weeks? I mean, depending on exposure to...
Yes. Well, that's the interesting thing about asthma.
to.
Asthma can vary tremendously from week to week, depending on whether you catch a cold and it goes right to your chest, or you have an allergy exposure, or a cold weather can provoke it. So although long-term, if you have fairly mild asthma, long-term it stays mild, or if it's moderate, it stays moderate. There are certainly these aberrations from time to time where your asthma can be worse, and it can vary tremendously, season to season, exposure to exposure. And that is part of the reason to make sure you have routine follow-up visits.
See, I guess I would think that if I was feeling different 2 months after I started medicine, maybe I should call the doctor's office and make sure I was still at the right dosage.
Yeah, and there are patients who certainly feel that and are proactive and get in to see it, but there are other patients that just don't realize that using their bronchodilator, their rescue inhaler, 3 times a day, they think it's okay because it helps them, but it really isn't okay. That means that they need to step up their preventive medicine so they don't need their rescue inhaler as much.
And I'm imagining that if they're not really closely following how they're doing, you're not going to have nighttime office hours or weekend. They have to go to the emergency room, right?
Well, we like to try to avoid that by having them come in routinely, and as in most practices, we have 24-hour coverage with phone calls, and we field them any time of the day. But your point is well taken. We would all rather see the patient at 2 o'clock in the afternoon rather than talk to them at 2 in the morning. And a lot of that goes into being on the right medicine, and also having sort of an action plan where a patient knows what to do if they're not doing as well as they should be doing.
Now, there is a plethora of choices in medicine, right?
Yes.
What are the different treatments that you can receive for asthma?
Right. Well, first of all, generally speaking, for the mildest asthmatic, and for those even have more severe asthma, you need a rescue medicine called a bronchodilator, which essentially relaxes the smooth muscle in your airways, opens them up, and it helps you exchange air better. And every asthmatic should have a bronchodilator, and some examples of those would be Ventolin or Preventil. And I brought one of them along, and these are these meter-dose press and breathe inhalers that you would use. So every asthmatic should have one of these as a first step. But beyond that, then we talk about for more significant asthma, more persistent asthma, then they need a so-called controller medicine. And there are 2 main categories of controllers that we would use. The first one would be called an inhaled corticosteroid, and some of the examples of those would be Flovent, or Qvar, or Elvesco, or Asmanex. And another main sort of cog in asthma treatment is something called a leukotriene antagonist. And the most common of those would be Singular. And there are some other ones we use, but those are the two most common maintenance controller medicines.
And what are the different side effects of the medicines?
Well, of course, like anything else, you always have to be wary of side effects and review that with the patient. With the bronchodilators, the rescue medicines, the most common experienced side effects would be shakiness and a little heart racing. But I would say most patients don't experience that, and those are not dangerous side effects. And if they do experience them, there are some other inhalers in the same category that are less likely to cause those side effects. With the inhaled corticosteroids, you have to be a little cautious with the dose that you use, because potentially if you use too high a dose long term, it can cause side effects not unlike oral steroids. So in children, you have to be vigilant monitoring their growth. You have to keep an eye in possible cataract formation or glaucoma or osteoporosis. But I should not overemphasize that, because when they're used at low or moderate doses and carefully monitored, the risk of any of these side effects is extremely small. And finally, with those leukotriene antagonist medicines like Singular, by and large, they're very, very safe medicines. Occasionally, someone gets a little stomach upset or headache, and then occasionally there's been some case reports where it may cause some personality or behavior changes, particularly in teenagers. So you have to be wary of all these as a practitioner. And it's important that the physician discuss that with the patient when they start in the medicine, so they can relate that to the physician if any of these are occurring.
Now, I understand a patient can't call you every time they're taking a medicine. Otherwise, you'd be inundated, right? But what if they miss a medicine dose? What would they have to do?
Well, many of these asthma medicines, if you miss a dose a week, you're probably not going to be in great trouble as long as you're pretty routine taking it otherwise. So if someone were on an inhaled corticosteroid for asthma, such as Flovent or Asmodex, and they're taking it twice a day, 7 days a week, if they take 12 or 13 of the 14 doses, they're going to be fine. What's important as a practitioner is always to query the patient, are they really taking it twice a day? Because they pretty much all know what they're supposed to do, but in real life, sometimes it doesn't happen. So I make it a point to really find out what they're taking and try to encourage them to be as close as possible to compliant with the medication.
So some of them are non-compliant with the whole regimen.
Well, absolutely. And you know what happens, too, with like any other condition, but particularly with asthma, someone takes a medicine, they do better, and they go, well, I'm better. Do I really need it? They take it less, and then they stop it, and then they get a cold, and it aggravates their asthma, and then they realize, I should have been taking it preventatively. So it's extremely important for these routine follow-up appointments to make sure a patient who has persistent or chronic asthma, they really stay on their medicines routinely, even when they feel like they're doing well.
So I know generally what happens to me is I let my prescription run out. I'm too lazy to call the doctor's office.
Right.
I'm wondering if that's a common thing.
They
don't take it for a few days, and then it's an emergency because they haven't taken it.
Right, it is all too common. And with asthma medicines, if someone has, let's say moderate asthma, chronic asthma, they should be refilling their preventive medicine monthly. So they should have 12 refills a year. And actually, if you look at pharmacy refill data in the United States, the average refill rate for preventive medicines for asthma is about 3 or 4 times a year, which is pretty horrible. So we have a lot of work still in the United States to get patients to understand that if you need to take an asthma medicine routinely, you really should take it every day. It's like a blood pressure medicine. You take that routinely, because if you don't, you can run into trouble. Same with an asthma medicine. If your doctor thinks you need daily preventive, you really need to take it.
And then you see if somebody runs out of inhalers, that maybe you've got to ask, more about symptoms, and maybe they need to be on something more serious, right?
Right. No, that's quite right. And I think one of the things that will be helpful for physicians over the next couple of years, as we do more and more electronic medical records and working directly with pharmacies, we may actually get data sent to our office and seeing when patients really are refilling their medicines. Right now, most of us don't have good access to that.
I'm sorry, go ahead.
No, it's sort of a way of checking to make sure patients are really doing what we would like them to do.
Are people actually sharing their inhalers or medicines?
Well, it's hard to get a good handle on that, but I'm sure anecdotally I've heard cases where there's a rescue inhaler, an albuterol in the household, and there's 3 patients with asthma, and they might share that as well. I think with the controller medicines, probably not as much, the ones they have to take daily preventatively.
Okay. Now, what about, let's say you're taking an asthma medicine and you're being treated for another disease.
Mm-hmm.
What kind of interactions might there be?
Well, fortunately, most of the asthma medicines that we use have very little interactions with other medications, which is a very good thing. The inhaled corticosteroids really rarely interact with other medicines. The leukotriene receptor antagonists, leukotriene blockers we mentioned, like Singular, rarely interact with other medicines, and the same with the bronchodilator. So we're in a pretty good situation where there's infrequent problems with these. So really that's something a patient shouldn't worry much about, interactions with the general asthma medicines we take.
See, I would imagine, not being a doctor, that if you had some kind of heart condition, that if you were taking something to, like, let's say, rapid heartbeat, and then you're taking something that creates a rapid heartbeat, you'd have a problem.
Well, you're right in that the bronchodilators, these so-called beta agonists, can slightly affect heart rate in some individuals, but usually it's very minimal. And even though there could be a warning about effect on hypertension or effect on heart rate, from a practical standpoint, it's extremely uncommon. And one of the difficult things patients have, now that they receive the package inserts that list all the side effects, is trying to discern what are common and important side effects and what are really rare side effects associated with the medicine. I think that's where the physician really needs to be proactively involved and mention, the few side effects that are more common that you really need to look out for. Because otherwise, if you look at the package insert as a patient, you would take nothing.
I know.
It'd be very difficult.
So I'm curious about cost of medication. Are any of these medicines very expensive?
Well, one of the difficult things in asthma now is most of these good medicines are not generically available. They're name brand, and so, they do end up having higher co-pays than obviously generic medicines. But most of the medicines are pretty well covered by the insurers, and there's usually a small to moderate copay you have to do. If you're unfortunate and don't have insurance, then they can be quite expensive, and then sometimes what you have to do is rely on your physician and potentially the pharmaceutical company to provide samples for you to use. And many of the pharmaceutical companies now, unbeknownst to patients, have really good programs for patients of low and even moderate income where they can get medicines either free or at a discounted rate. And whether you go through the doctor or the website, there's a lot of this information out there that I think patients don't take good advantage of.
Yeah, I'm thinking you could get into a catch-22 situation where you're non-compliant with your meds, then you're too sick to go into work. You're too sick to go into work, you're not making any money. Then you really have a problem.
Then you too have a problem. But hopefully, if you get on the right medication, you bounce back, and then you can be an active member of the community and work effectively.
And one last question about treatment. Are there any new therapies that have been developed?
Well, one interesting therapy that's been developed in the past half dozen years is a medication called Xolair, which is an injectable asthma medicine for the most severe asthmatics. And what it does is those allergic asthmatics that may be very allergic to dust mite or animal dander, this particular injectable antibody knocks out the allergic antibody in your system and has been proven to be quite effective in improving the quality of life of severe asthmatics.
Wow.
And although we don't have a huge number of patients on it, those patients with severe asthma have done very well on that. So that was probably the main new treatment in the past 5-6 years. I think
That's exciting.
Yeah, that is very exciting. And there's a lot of research going on for other modalities of treatment, but nothing that I expect to be new in the next couple of years. I think the only other thing that's really come out in the past 5 to 10 years is the fact that inhaled corticosteroids used routinely by patients who have persistent asthma really lead to very good outcomes and cut down emergency room visits, hospitalizations, severe asthma attacks. And I think what we've seen in the past decade is physicians have been much better in prescribing those medicines. Now all we have to do is get the patients to really take them on a routine basis.
Comply.
That's
right. Okay, and one last question about obesity rates. Does obesity affect asthma, and does asthma affect obesity?
Yeah, it's an interesting question, and there is some preliminary research and some ongoing studies going on that suggest that obese individuals are more likely to develop asthma. And one of the theories that also is put out there into the increasing asthma epidemic is it may have something to do with an increase in childhood and in adult obesity. And furthermore, of course, on the other hand, if you have severe asthma and you're not on the right medication, that can also lead to obesity because you're not able to exercise as fully. So there's some interesting stuff going on with this, and I think, the idea that children and adults should exercise more fully, lose weight, keep their fat levels down would be, very important and very helpful.
Okay, so that might be some of your medical advice.
Right.
Is to lose weight.
Well, always good advice, and there does seem to be some link to asthma. One other thing, just parenthetically, there's some research now that's suggesting that vitamin D deficiency might also play a role in asthma.
Oh.
And although that's not fully worked out, it's an area of active interest and in a lot of fields, medical fields, but including asthmatic condition.
And do you ever suggest to your patients to change, either take the carpet out of their house, or, I'm sorry to say, I don't want to say get rid of your pets, but...
Find another suitable home. Well, no, absolutely. I mean, this is one important thing an allergist does with an asthmatic. If we identify that someone is quite allergic to cat dander and if they have a cat in their house, we really do try to convince them to find another home for the cat. And if they can't do that, keep the cat outdoors, or keep the cat as far away from the bedroom, or perhaps put an air cleaner in their bedroom. And there's even some evidence if you bathe your cat regularly, if it's safe to do such, that
I would be afraid to do that.
That's right. That can also diminish the amount of allergen exposure in a household. So environmental control measures are very important, and pet exposure avoidance and dust mite avoidance by removing carpeting, washing bed linen in hot water, putting allergy-proofing casings over mattresses and pillows. All this can be quite beneficial.
Okay. Then they have to move to Arizona, right?
Well, there's plenty of allergy in Arizona as well. It used to be said that you should move to Arizona, but now everyone irrigates their little piece of property and grows their grass and their trees and has the same indoor allergens. So unfortunately, there's little escape from allergic disease.
Great. Anything else you wanted to mention, or you think we covered everything?
Well, I think we have done a good job covering the field of asthma, and I think, just the reminder is if someone's experiencing symptoms, to review it with their primary practitioner, get on some preventive medicine, and then if they find that they're not doing well with that, then maybe seek specialty care to look at allergic triggers and do some more in-depth testing. Okay.
And let's just mention the web address for Certified Allergy.
Oh, okay, yes. We're at certifiedallergy.com, and there's some good information there, links to national organizations. We list pollen counts for the community so someone can find out how much tree pollen or grass is in the air. So I think individuals will find that a useful link.
Okay, and then we'll just mention the telephone number.
Right. Our main office phone number is 434-1446 in Albany.
All right. Dr. Scott Osur, thank you so much.
Well, thank you very much, Peggy.
Thanks for watching. We hope to see you next time on Focus on Health.